This is Agnes, the presenter of Sickle Cell Talks with Agnes. Welcome to my YouTube channel. So stay tuned because every week we'll be posting videos about any topic in sickle cell disease. We don't have set days yet, but just turn on the post notifications for you to be notified every time we post a video. Thank you and stay tuned. If you've got any questions, get in touch with me on social media or social media platforms. Thank you. We will bring in Professor Joy Ho to give her presentation, please. Thank you.
So I've just shared my screen. I probably will just use the slide format like this because I gather sometimes it doesn't work very well if I do the projection screen. So hopefully this will work. So I'm going to talk about sickle cell disease in the adult. I was given 10 minutes and I hope I'll keep to time. I would just say that, first of all, that there are estimated to be about 50 million heterozygous sickle individuals in the world. And this really emphasizes the importance that I think yesterday and today that Agnes has been trying to emphasize the importance of testing, for instance, of prospective parents, given that as Australia increases our intake of migrants from various communities in which sickle cell prevalence is high, that we really need to get the word out to enable people to be aware of this and to have appropriate testing. So just a number of figures that are derived, some from a publication a bit earlier, but nevertheless is still very relevant to the scale of the problem. So in Africa, there are about 200 to 300,000 sickle cell disease newborns per year, but significant initiatives have been made in recent years in newborn screening. And I work on the International Committee in the American Society of Haematology, and even ASH, which is the American Society, is actually doing a lot of work and assisting in that area. In the US, there are 60 to 70,000 sickle cell disease patients, and there's one newborn per 600 births in the Afro-American population. In France, it is estimated about 10,000. Now, in Australia, however, there are no definitive data. And through the efforts of Dr. Anthea Greenaway and Dr. Kylie Mason, who really in the last few years have taken a lead in bringing people together to look at sickle cell disease. At a meeting last year, just in terms of a very general estimate, we think there are about 1,000 sickle cell disease patients, and that is certainly increasing, as I said, with the immigration patterns. But this lack of definitive data really reiterates the importance of how that we need more research, and as a result, a new registry has recently opened, and the word new should be in inverted commas, in that we have had a hemoglobinopathy registry for which I am actually chair of the steering committee since the early around 2011. And the difficulty there is that we haven't really been able to get it off the ground very well. We've collected a large number of thalassemia patients, but in recent months and in the past year, there's been an increased initiative, an impetus to collect data on sickle cell disease, and we will welcome any continued support to achieve more granular and better data on the state of play in our country. So as far as distribution of sickle cell disease, here are the main groups in the Afro-Caribbean communities from the Mediterranean, and this in the earlier days, most of our patients were from Italy and Greece, also in India, and also we have now an increased Middle Eastern population. And interestingly, that it has the same relationship with the distribution of malaria historically as thalassemia. And I don't have time, as I only have 10 minutes. I won't go into the mechanisms or scientific mechanisms of that, but more than happy to chat. Now, most of you will know this, but I'll quickly say, so sickle cell disease is due to a mutation in the beta globin gene in a specific molecule, specific. So the globin is the protein molecule in a specific amino acid, which is called number 6. As a result of this mutation, the sickle hemoglobin, that protein, undergoes crystal formation when it becomes deoxygenated, when there's less oxygen, and aggregates into and arrange into rod-like fibers. As a result, it leads the red cell to deform. And in addition to that, there is also loss of the membrane of the red cell and changes in the ability, changes in the permeability of the red cell membrane, leading to irreversibly sickled cells. This audience knows all about it, but my non-hematological colleagues, for instance, are always very interested in the fact that they have such an unusual conformation. And one can imagine in the old days when people look down the microscope when the disease was first found, that they saw these literally red cells in the shape of sickles. I won't go through the rest of the mechanisms in detail, but just to say that various channels that of potassium and water loss are affected, leading to dehydration of the red cells. There's an abnormal adhesion of the sickle cells, not only to themselves and to white blood cells, but also to the endothelium, which is the lining of the blood vessels. This leads the red cells to become more fragile and break up and therefore cause a chronic anemia. And the rigid cells in forming aggregates, one of the major problems is that it leads to a blockage of small blood vessels and therefore leading to infarction of major organs. I'll very briefly skip through this next slide. It summarizes some of those scientific mechanisms, but just to mention, for instance, that it does not only affect red blood cells, it also affects platelets, which are the cells in the blood that normally cause clotting, and they're activated, and sickle cell patients have an increased tendency to clot. It affects the lining of the blood vessels called endothelium. The fact that the blockage of blood vessels leads to low oxygen as the tissues become more reoxygenated, meaning there's more oxygen, that in itself can set up inflammation and cause harm. And an important aspect is that the process of hemolysis, which is red blood cells breaking up, leads to reduction of nitric oxide. And this is a molecule which I, again, won't go through the very specific biochemical mechanisms, but the main thing is that the lack of this molecule called nitric oxide, because nitric oxide is a vasodilator, meaning it dilates blood vessels, the lack of it leads to a number of conditions like pulmonary hypertension, which is like having high blood pressure, but that blood pressure is in the lung, and that can in turn affect the heart. It can lead to strokes in the brain and lead to ulceration, for instance, in the legs. Interestingly, and consistent with the way that the disease is caused, the mechanism is that there are a number of factors which make the disease, that can make this disease more severe. For instance, the level of oxygen in the red blood cells is very important, because the lower the oxygen, the more the red cells sickle. The level of hemoglobin, that is that protein concentration, the protein that is abnormal, can also increase. The higher the level, because of the increase of viscosity, that is the thickness of the blood, can increase sickling. And thirdly, what is very, very important to understand is that there is a form of this hemoglobin, which is the molecule that is affected in sickle cell disease, in the development of an individual. In the fetal stage, there is a particular form which disappears in the adult. But if you can maintain high levels of this fetal hemoglobin, this fetal form of the hemoglobin can inhibit the polymerization or the aggregation of those sickle cells. those sickle fibers to form sickle cells. So here are, in brief, the manifestations, which I will just list. I already said the red cells break up, and therefore you get chronic anemia. In children, there is this hand and foot syndrome with inflammation of the finger, of the hand and feet, and we talked about it actually last night in the red cell symposium. There's also painful crisis, which is one of the most important manifestations, where the blockage of blood vessels leads to infarction of bone, leading to generalized pain. Brain syndrome, where there are blockages in the brain, leading to stroke-like syndrome, sometimes to permanent neurological damage, even in children. In the lung syndrome, we can have infarction of the lung tissue, leading to shortness of breath, or otherwise called dyspnea, chest pain. Priapism, which affects the penis, which can be a very distressing symptom. In certain situations, such as contracting a particular virus called parvovirus, this can lead to aplasia, meaning that the bone marrow doesn't produce, markedly decreases in its production of various blood cells. And there's also sequestration, which is a way in which the spleen traps the red blood cells, and suddenly the red blood cells level completely drops down the bottom. Then the more long-term effects include avascular necrosis, which is a term which we use for the effect on bones, especially in the hip joint and the shoulder joints, where the heads of those long bones die, and therefore cause chronic issues, particularly of the hip. Infection, particularly of bone, called osteomyelitis, and also the effects on kidney, which can lead to kidney damage. I've already mentioned the lung hypertension, and ulcers, and also gallstones, and also proliferation of the red blood, of the blood vessels in the eye can lead to significant damage to the retina of the eyes. So I'll now talk about management in brief. So first of all, some supportive management. Of course, we avoid precipitating factors, which include low oxygen infections and dehydration, because the patient can have repeated infarction of the spleen, and we call that hyposplenic, because the spleen is really the garbage tin or the filter of the body for various infections. Patients would therefore be susceptible to infections like pneumococcus for pneumonia, meningitis with meningococcus, and Haemophilus, as well as malaria. And therefore, it's important to administer appropriate vaccines. We treat the crisis by treating the precipitant, which can often be infection. Sometimes there is no particular precipitant, with intravenous fluids, oxygen, pain relief, and sometimes we need to transfuse. With the lung crises, people may have to be admitted to intensive care and may need exchange transfusion, which we again spoke about last night, where we take away blood and give back, take away the affected blood with sickle cells and give back donor blood. For surgery, we often have to provide, as particularly more severe surgery, we have to perform an exchange transfusion before then. And now I will talk about the drugs. So first of all, the anti-sickling agents, one of which is hydroxyurea, which should now really be considered the mainstay of treatment for sickle cells. The main way in which it works is that it increases that hemoglobin that occurs in fetus, called fetal hemoglobin, which reduces sickling, but it also reduces white blood cells, leading to reduced sticking of the sickle cells to white blood cells and the reduced blockages in that sense. So here we have fetal hemoglobin induction. The mainstay of that is hydroxyurea, although there are other less commonly used drugs, such as L-glutamine, which is a short chain fatty acid. And indeed, hydroxyurea and to a much lesser extent used the L-glutamine are the only FDA approved treatments for sickle cell disease until a few years ago. And I should really change this slide, because there are two others which are now approved, and you can see that under newer agents, Crizanlizumab and Voxelator, and I'll talk about that in a minute. Where I put P-selectin, it should be P-selectin for the Crizanlizumab. Of course, I'll briefly speak about red cell transfusions, and I have already told Anthea I won't talk about transplants because due to the increased effectiveness of transplants in children, it is predominantly still a pediatric procedure. So the effect of hydroxyurea is summarized on this slide. It increases fetal hemoglobin, as I said. It reduces pain crises, high hospitalization, transfusions, decreases mortality, and decreases neurological events, although it is felt that this is an early study, that there is insufficient kind of evidence to say that it definitively does that in adults. There is low level evidence in children. So many people like myself, when we deal with a brain syndrome, we would still choose to use transfusion to prevent recurrence rather than just hydroxyurea. And here are the indications for transfusion, including multiple crises, stroke, chest syndrome, severe hemolytic anemia, aplastic crises, for the long-term management of chronic pain, when patients have not responded to hydroxyurea, repeated painful crises, splenic sequestration, that very drastic effect in children, and maybe Anthea will talk about it, where suddenly all the cells are destroyed in the spleen, and people and patients, young patients, lose all their cell counts. That is clearly an indication to try to prevent it from happening again with transfusion. Importantly, recurrent stroke, definitely we would consider putting patients on transfusion, and as I said, acute chest syndrome. Stroke and chest syndrome being the most common causes of death in this disease. So simple versus exchange transfusion, I've already alluded to this before. The advantage of taking the sickle cells out and replacing it with donor red cells, which is represented in the bottom diagram, is that the thickness of the blood, called hematocrit, is reduced. So when you do a simple transfusion, you raise the thickness of the blood, for instance, in this case to 40%, and you have more sickle than hemoglobin A. Whereas here, when you remove the sickle cells by what we call phlebotomy, which is essentially something like giving blood, using a cannula to take blood out, or using a machine called an apheresis machine to remove the sickle cells, you can see that the thickness of the blood can be reduced without therefore increasing the propensity of sickling due to the transfusion. And you can see also that the percentage of sickle cells by the exchange is reduced as well as compared with simple transfusion. Here I won't go into detail, but just to say that there are specific indications for stem cell transplant for sickle cell disease, and this includes stroke, this includes sickle lung disease and nephropathy that is severe, and I might let Anthea talk about that. And in the final few slides, I'll just mention the two main drugs which have passed FDA approval. Obviously, we hope one day we will also get that in Australia. But this first one is Crizanlizumab, which is a humanized antibody targeting the molecule called P-selectin. So P-selectin is a molecule that leads to the stickiness of white blood cells and platelets to the sickle red cells. So if you can target that sticky molecule, you can reduce the sticking of those red blood cells together to cause blood vessel blockage and infarction. And the main trial, called SUSTAIN, was published a few years ago now, had almost 200 patients, which compared people with between having the drug versus placebo, and you can see they were divided into the number of crises events, and in both groups, the more severe as well as the less severe, there was clearly an improvement in the probability that they would have painful crises in those patients who received the medication. And the other drug, called Voxelator, I always find it hard to know whether I'm pronouncing it correctly, but this drug is also very interesting because it inhibits the sickle hemoglobin from aggregating because it binds, it stabilizes the sickle hemoglobin in the oxygenated state. That is to say, it basically increases the oxygen that is stuck to the abnormal molecule, preventing it from forming those rod-like fibers that we spoke about before. And here there's another trial called HOPE, where they were able to see that patients, that there were significant increased numbers of patients who had a response in those who received the highest dose of the drug as compared to the placebo or to a lower dose of the drug. And on the right-hand side, you can see that the mean hemoglobin level in preventing the red cell breakage was also the highest in patients who received the highest dose of Voxelator. Actually, I do have 2 extra slides, and that is to introduce the subject of gene therapy. Many of you will know my unit performed gene therapy for thalassemia patients. We have been trying to see if we could perform the sickle cell gene therapy trials in Australia, but so far we have not yet been able to achieve that, but we are continuing to try. This particular molecule called BB305 was in fact the one we used for thalassemia, but it so happens that it also plays a role in reducing sickle polymerization, sickle hemoglobin polymerization, because it acts like the fetal hemoglobin. And the way gene therapy works is that a particular virus called lentivirus inserts this particular gene into the genome of the patient. They then make this molecule, and this molecule then prevents sickling. And furthermore, my penultimate slide is to say that there are certain molecules which actually represses that fetal hemoglobin production. And therefore, if you can use gene editing to target those molecules which suppresses fetal hemoglobin, you will then raise the fetal hemoglobin to reduce sickling. And that is another form of gene therapy in sickle cell disease. So I come to the end, and I'd like to summarize by saying, clearly, as you all know, sickle cell disease is a common disease around the world, but is becoming increasingly common in Australia, conferring multi-system morbidity and even mortality. There are increasing efforts in newborn screening, but it remains a worldwide problem, causing an enormous impact on well-being. There are multiple pathogenic mechanisms, which I hope I've been able to go through in a very brief, but hopefully clear way. But they are also the way in which research can be advanced, because these advances target those mechanisms, such as those molecules that cause stickiness of red cells. While hydroxyurea and transfusion remain the mainstay of therapy, exciting developments directly targeting those mechanisms are being developed, and there is clearly a continuing need for more basic and clinical research. And as I mentioned, I did not mention much about stem cell transplant because the pediatricians are clearly the better experts in that. Thank you.